I'll start, Patty, and then I'll hand over to you. So welcome everybody to our clinical network around unplanned pregnancy and abortion. And I was going to say Victorian, but we've also got some people from interstate this evening. So a very warm welcome to you. And it's also not necessarily rural, because we also have some people who are in the metropolitan regions around Australia. So welcome to everyone. I'd like to acknowledge the traditional owners of the lands on which we meet today across Australia, and pay my respects to elders, both past, present and emerging, and to acknowledge the land has never been ceded, and that our Aboriginal communities take care and respect the land and continue its care. For this evening, we've got a couple of things on the agenda. I'll hand over to Patty in a minute, and just a reminder to keep your mute function on if you can. We want to make it as informal as possible, but at the same time reduce the background noise. And there'll be time for discussion, and please feel free to use the chat function to pose questions or comments and to introduce yourselves. And over to you. Thank you, Patty.
Patty, sorry, you're on mute, Patty.
Yeah.
Sorry, I'm having mute malfunction syndrome. Sorry. So Carolyn from 1-800-MY-OPTIONS, I've got you down as the first agenda item, just to give us all another snapshot update. It's always really good to get a snapshot of what's happening via your the database that is also 1-800-MY-OPTIONS. Thanks.
Hello everyone, and thanks very much for having me. I'm Carolyn, I'm manager at 1-800-MY-OPTIONS. So we have had a pretty stable situation with our callers lately. So again, we are seeing a lot of callers who are experiencing financial instability. Again, it's around about 40–50% of our callers are experiencing that. So obviously looking for either low cost or bulk billing services. We've had a slight increase in callers who are looking for contraception. So there's been a very steady trend through COVID that there's a little bit more demand for contraception services, particularly for LARCs, which is, you know, it's quite exciting. We really like being able to refer people to IUD and Implanon providers around. We have had consistently still some of the people who are presenting at later gestations than otherwise we would expect, and still this is from women's reports coming from the fact that they have a level of distraction at the moment with COVID. A couple of points that I thought things that I thought I'd raise in relation to the discussion topic around reproductive coercion today was that we are seeing obstruction for women who sorry, not reproductive coercion, for conscientious objection. I'm so sorry. We're seeing a lot of obstruction from practitioners consistently at our service. It's not huge, it's still only a couple of people a week, but people who are being bounced around a particular clinic because one clinician is an objector and they get bounced around to another one. We would see cases of this happening a few times a month, and the other is where a person has a GP or other clinician who is a conscientious objector and so obstructs their provision of services, and so they will continue to delay that person until potentially they are beyond a gestation where they can get local services. And I think that's the more common one that we see for rural women, where the GP is telling her to wait a little bit longer, delaying her access to ultrasound, delaying access to other types of workup that might be needed for her to be able to make a decision, and just general delays, misinformation. So we do keep a little bit of data on that. The numbers are not huge, but they're significant enough that we do have a level of concern around this. So yeah, thanks everyone.
Could I perhaps ask an inquisitorial question? Is there any pattern to it? Are names coming up? Is it in an area? Is there anything that we can draw from this? Is
Unfortunately, yeah.
Same offenders, if you know what I mean?
Yeah, questions are great on this stuff. We don't have a level where we would see specific patterns. One thing that I can say is that it's happening across every region of Victoria, including metro and rural. So it is consistently, we are seeing conscientious objection across the state. Interestingly, we had a really great interaction with a conscientious objector recently who called us to say, look, I don't like abortion, I don't want to be doing this, but I know I've got a legal obligation, and I also know that this patient that I'm working with can't have a baby at the moment, so help me meet my legal obligations. And I think that that's a really great way that 1-800 can support clinicians who don't want to have anything to do with comprehensive SRH services, but want to meet legal obligations.
So is that the kind of referral that you've had often, or is that quite an extraordinary interaction with a GP?
That level of admitting that they are a conscientious objector because of religious reasons is a little bit more out there. But speaking to a GP who just doesn't want to have very much to do with SRH and doesn't really see SRH as their business is relatively common.
Yeah.
So we're quite grateful that we're on the health pathways across Victoria, so that if a GP bothers to look at them, they'll be able to find us. Yeah.
And I guess another contextual one, because this is going to slide really nicely into this week's topic, isn't it? Is, do you get a sense from women about whether there's a health literacy around the fact that they don't need to go to a GP to get a referral? Or do you feel that that is still a commonly held belief?
A very commonly held belief. There are some services that do require a GP referral, but they're not as common. And so it is definitely a barrier where women just presume that their GP is the gateway to SRH services. Absolutely.
I mean, that might be a topic for another day, but it's something I've been thinking about quite a lot lately about, is there a piece of work we can do on, you know, messaging young women or through education services? You know, some of you might have some comments about this, to improve health literacy, because we're not going to necessarily convince all of the doctors to behave like the doctor that you just had an interaction with. And we know how hierarchical the interaction between the patient and the doctor can be, and how people will be really, really put off sometimes, you know. And, you know, we've had quite a number of patients reflect to us on what was said to them in the room, or the attitude, or, you know, all of those sorts of things. And it's such a vulnerable moment for the woman. And just wondering, before we get onto my presentation, does anybody want to comment on that, or share anything, or any thoughts they would have about how we maybe as a group could look at ways of messaging people, you know, or a campaign to get free pregnancy testing out and about? Any comments?
Hi, Patty. It's Louise Holland here. Hi, everybody.
Hi.
This is really interesting. This is really interesting, because I think one of the things that happens if you look at how people make appointments to see GPs is there's online booking, or, you know, they might ring up a service. And I think particularly the hub services, it would be really worthwhile having, kind of some front of house, education and information in regards to, kind of what is available and what, even if it was a very generic sexual and reproductive health services, some can be, directly referred to by self, or you can talk to a nurse or something like that. So, having quite a targeted campaign, I think, would be really useful. And of course, getting to those people who work with women, I think, is really critical. So getting to that secondary layer of workers, whether it's be a counsellor, a maternal and child health nurse, anything like that there's information there. I think that's, some basic health promotion, health promotion kind of activities, I think, would be really useful, because women are really surprised when you say you could actually do this all by yourself.
Yeah. And even at that secondary level, it's quite common for health, para health and health professionals to think that you have to see a GP because of the whole Medicare side of things. So I think there's a really big body of work to be done there on sexual health literacy. Any other comments before we go on to?
I was just going to highlight the campaign that 1-800 My Options did through their Instagram or social media channels anyway, around targeting women and increasing, messaging around medical abortion is an option. Because I think that's one of the drivers for GPs to think about providing a medical abortion service, if enough of the women or pregnant people that they're seeing are requesting a service. And the better, we can educate people requesting the service is going to support system change.
And just any other comments? Any chat come through? Kylie, I've got 20 on the chat. Does that mean there are 20 comments on chat? Do you want to check them?
There's 28 participants.
There's under chat, it's got 20. So I'm just wondering.
That's 20 people have responded, have said something. So either provided their details or made a comment.
It's not that 20 people want to ask a question, because I haven't been looking into that. Okay.
One thing I did see on chat, and Yvonne might want to speak to this, but up at Yvonne Barnes is here from Mallee District Aboriginal Service, and reporting that there's a new medical abortion provider in Swan Hill.
Do you want to unmute and tell us? Yes, go ahead.
The service is a self-referring service. Somebody can contact the Women's Health Department at Swan Hill District Hospital in the primary health section there, and then they will follow through. The woman can have, we've sent a referral and we've sent results from the GP, but otherwise they can just self-refer and Swan Hill will follow up all of it. But they don't have to have a referral from the doctor or any blood results or anything like that. So we've used it a couple of times since our last meeting, and it's great to have that service locally.
And is word of mouth getting out about that service? Because we certainly heard from the provider that there's a steady stream now of clients.
I actually learnt through the pharmacy. I was ringing up after our last meeting. Someone said there wasn't a dispenser in Swan Hill, and I was trying to follow up an MTOP for a woman, maybe down at the Women's. That was checking that there was a provider, a dispenser in Swan Hill, and they said, oh yes, Swan Hill's been doing it, but been doing it a couple of weeks. So I think the word's getting out now. Certainly at our service, I've made everyone aware of it.
I bet you have. That's great. And I think when you have a local champion like that, things really start to pick up. Carolyn, are they on 1-800?
They are, and you should have heard the cheering from our team when they updated the MTOP status. It's very wonderful. Good.
Yeah. It's just great. It's just great. Yeah. All right, so without further ado, should we move on to what we were going to talk about? And this segues on from comments made by your good self, Louise, at the last meeting. Don't grimace, it's all good, it's all good. Just you shared the story of interviewing someone who said they didn't want to be, they wanted to be a GP in your practice or a registrar, but they didn't want to be involved in this area of health, and just how would we respond? So that led to a general, very quick discussion at the end of our last session about conscientious objection. And so what I'm presenting tonight is sort of a gentle introduction into how we might talk to our colleagues around some of these difficult issues. I'm not really pitching it at the level of what Carolyn's been describing, of, you know, real sort of perhaps a well-practiced objector who, you know, is obstructing. I'm really more thinking about, we might have a discussion about that later, about how our ethical response to that would be. But this is more about having those, starting to feel comfortable about having those conversations with people who are trying to think the issue through, and not just always assume there's a them and us about this whole area. So I'm just going to share my screen now, and I'm going to give you 3 interactions, and they're bare brushstrokes in each interaction, and then we're going to go into how we might approach it. And I just want to let you know that I have developed a backstory about this young doctor. I've developed their entire life story and a whole load of things. So there's lots of things that you can inquire about, and I will tell you about as we go. Okay, so you can be the detectives. So, oh, here it is. So I've called it a conscious commitment, a morality tale in 3 slides, just to be really brief, about how to discuss the conscience, issues of conscience with colleagues and trainees. So the first interaction is the interview. Juan is a GP registrar who applies for a job at a sexual health hub, sexual and reproductive health care hub, one of the funded hubs, and you're on the interview panel. During the interview, she's asked if she's willing to be involved in the provision of early medical abortion. And Juan states that she's happy to be involved in all aspects of women's health except abortion. So I want to maybe open it to the group about how we might proceed, or what questions or responses would encourage discussion. So I think, Louise, this is roughly based on your experience and whether or not you offer someone a job like this if they say no, they're not going to be involved, or they don't want to be involved. Does anybody want to, and no answer is wrong, just reflect for a minute or two on, a moment or two rather, on any time you've had a discussion like this, maybe in a tea room with anyone, what you've done yourself. Have you encouraged them to talk about it, and how we might move from what might initially feel like an awkward moment. So Louise, I'm going to ask you to just do a wee bit of work first. So you know, one response is you wouldn't consider the person at all for the position because you've got a set of criteria. Another response would be they may have an awful lot other things to offer, and there may be more that you could discuss with them. Do you have anything you want to share?
I suppose, and I'm mindful that my team is here tonight, so that's really good. So hopefully someone else will add to the discussion. So the big issue that came to me was having, you know, working within a hub and working with GPs for quite a few years who are very keen to have the initial discussions around reproductive choices, but not go on to complete the training and actually provide earlier medical abortion. We've kind of left it alone and then veered towards those who do, and kind of, well, that's your right as a medical professional, and I respect that. And I suppose what the reflection was is when we actually have a program where we are encouraging doctors who want to become GPs and have actually identified at other parts of interviews, during the interview, that they are going to be working in rural and regional, so they're not going to be GP and go back to metro, but they're actually going to be happy to work in small country towns or larger country towns. I thought, well, if all the other components of their extended skill set would enable them to provide really great, fantastic sexual and reproductive health, then maybe by participating in a program that we have in Bendigo, that there may be some shift, because a lot of the times it's actually exposure to women and their stories, and exposure to the complexities that what Carolyn was saying is that that some GPs actually, you know, over a period of time, and whether it's maturity or whether it's just experience or whether it's just exposure, can actually change their mind. And I don't know if you remember, everybody who is around when access to early medical abortion became legal in Victoria, and we had all those GP evenings, and we had, you know, 1 or 2 champions in every GP dinner night that Serge put on, and yourself, Patty, came and spoke about it. And it's amazing now when I think of those GPs who all those years ago just really wanted to come along and hear about it, and now they're actually practicing and providing the service. So it's a time thing. And so I kind of think that, you know, if that it's not necessarily not negotiable, but it certainly would be very difficult if a GP came into a service and they were expected to do that and they didn't, then that service would no longer exist. And that's what we've dealt with when GPs come and go from rural towns, do you know what I mean? So, you know, in Swan Hill, Echuca, Kerrang, you know, it's so GP reliant, and I think that's the other issue that's probably not necessarily talked about tonight. So there's some of my thoughts.
So would those be the sort of thoughts that you would feel in an interview you could feed back to Juan? You know, do you think that you could, and what do other people think about this, feeding back to her that, you know, the function of the service and how we, you know, you need a provider because there's nobody else? And does anybody have any comments about that, or any comments about any other questions that you might feel are a little bit maybe not your usual interview questions, but might be very helpful in this situation? Like, rather than move on to the next thing, which is, are you credentialed in implant-on insertion, you know, to just stick with the awkwardness of her saying, I don't want to be involved.
Sorry, Patty, Kathy, you might want to try and sort out whether it's just carte blanche that she wouldn't be involved at all.
I'm struggling to hear whoever it is. Sorry.
Oh, sorry, Patty.
Oh, hi, Kathy. Yeah.
Hi. Sorry. Yeah. Can you hear now?
Yeah, better.
Yeah, you might want to try and tease out a little bit whether it's carte blanche on abortion, or whether she might be happy to be involved in aftercare, which would probably make it a difference, because you wouldn't sort of want someone rocking up to someone in the practice who wouldn't provide aftercare, whereas if it was known, if you had other people and she wasn't providing, it might be a workaround.
Yeah, yeah. Anybody else?
Can I say something, Patty? It's
Purnia. Yeah, I really want people to say things, so yeah.
I think Louise was talking to...
This is Purnima?
Yes.
Yeah.
So just regarding this interview that we we had it in our community health services recently. We interviewed, actually they were all very quite good GP registrars. We did ask quite a variety of questions, and including questions about their views on medical termination of pregnancies. So we also asked about morning after pill. Those 2 questions were specifically asked. The reason for objection for MTOP was mainly because of religious belief. So they said that they were quite happy to provide morning after pill because they don't know whether the patient is pregnant or not. And for the next question, because they know there is a pregnancy and a live fetus, so because of the religious grounds, they can't provide that service. But they're quite happy to organize like a blood test or ultrasound scan, and then organize the appropriate referral for the woman to seek that choice, whatever the patient wishes.
So they were happy to do the workup and
That's correct.
refer her to someone else. Yeah. And possibly then also do the follow-up. Is that what you're saying?
Yes, that's correct.
Yeah.
Yes. Yeah.
So as Kathy said, not a carte blanche. So not a no way am I being involved with these women.
No.
I'm just wanting to suggest that maybe we could even ask her to explain a little bit more about, and you alluded to it, that most of them seem to be religious reasons. And if we could just, do you think it's appropriate, and even in an interview situation like that, to just gently feedback that you're really interested in her thought process around why some parts of women's sexual health are okay and others aren't? Do you think that that's an appropriate thing that you would like someone to be able to articulate around in terms of their conscientious objection? And I would argue that I think I would be encouraging us to have those sorts of discussions with people. I think because it's a bit of a taboo, you know, we shy away from it. And in our college, we just ask people yes or no, and they're allowed to just say no. They don't have to articulate any reasons around it. And I would venture that even the conversation around articulating your thoughts can be really useful in terms of moral development and moral discussions with colleagues. So I'm going to, in the interest of time, I'm going to suggest that you might have had a conversation like that. Can you tell us a little bit about it, Juan, why you feel that way? Or another strategy that I've used myself is to say, you know, when I started in O&G, I was really uncertain about what direction I was going to take as well. And I would be really keen to have a discussion with you on another occasion about this, something like that. Anyway, Juan takes up your offer of having a bit more of a discussion, and what she tells you is that she's Vietnamese, and she attended Melbourne Ladies College in Melbourne. She's the second child of 4 siblings, and her older brother is an engineer. She's a doctor, and her next sister down is a physiotherapist, and their 4th sister has severe cerebral palsy, having been born at 24 weeks and is living at home with her parents. And Juan always found this a very challenging situation at home, but she saw the love that her parents gave to a disabled child. And so she always felt that every child deserved a future. When she was at university, she became involved in the Christian Union. And so she has quite a lot of experiences of people talking about religious beliefs about abortion. So she comes from that kind of a background, but she demonstrated a lot of sensitivity around talking about her younger sister and the complexities of life. And so you suggest, as the interviewer, because really, I'm going to again just make up this factious case, she was the best interviewee in all the other scores compared to somebody else, 2 other interviewees. So you give her a chance, and you suggest that she joins the team, sees the kind of patients that you see, joins in the team discussions and team debriefings that you have, whatever your service provides, and even possibly encourage you to sit in on a consultation. And the methodology behind that is to hear the stories. One of you was talking about hearing the stories from women. So we don't give up on her. That's the first part. We don't write her off. And if you remember the little, I think Kylie, you sent out the reading that I had talked about, where the author of Scarlet A talks about teaching ethics around abortion by having a Christian who opposes abortion and a Christian who's for abortion, to sort of show the differences in opinion and how each can be respected and discussed. Anyway, Juan comes into the team and she is really keen to sit in with you, Louise. And so I'm keeping it with that. Yeah. So she's keen to sit in with whoever was interviewing her. And so the second act in the morality play is the consultation. So she sits in with you for a consult. Josie's come for advice and referral to a service beyond the hub because she knows she's further on, but she's the hub has got such a good brand in the area that she knows that she'll get really good consultation and respect from the nursing staff there. So she's 23 years of age. She's gravida 1 para naught, and she's currently at 14 weeks gestation. Now, the story that she tells you is that this was an unplanned pregnancy, but initially she and her partner were very pleased about the thought of becoming parents. However, during the first 8 weeks, his occasional violent outbursts towards her increased, and she has recently had a broken arm and has decided that she needs to relocate back to where her mother is in Queensland to get away from this situation. She also shares with you both a past history of childhood physical abuse and previous intimate partner violence. And so this is someone that you're going to be referring on to another service, perhaps the women's, perhaps somewhere else. But it's another opportunity to have a bit of a discussion. And what sort of things might you want to discuss with her after you've made the referral? So she'll see you talking to the patient, she'll hear the patient's story, and then you could arrange a feedback or debriefing session afterwards. Do any of you want to suggest what you might talk about or ask her more about? Again, all responses are totally fine.
Is this we are asking the registrar who is sitting in with Louise? Yeah,
Louise is featuring really big in this one. yeah. So whoever the person is to begin with that employed her is now doing a consult, and the registrar, who doesn't want to be involved in this sort of care, has been encouraged to listen to a few stories and to pay to come in. And I have done this myself with medical students and with trainees who've had an ambivalence around where they stand.
Yeah, basically asking how did she felt the consultation went, just to get her idea or her views on the consultation that was just happened between Louise and this patient. Just to get her views, because there are quite a few important things which are quite alarming in the history, and which might be the contributing factor why the patient is requesting the MTOP. So initially, we would like to know how she felt about the consultation, what she would have done differently, or what she would have done other than what Louise has done for the patient, and what are the pros and cons in deciding what the decision the registrar would use to take. So those are the few questions.
So what she might have done differently, and so what was the other point?
What she was done differently, and if so, what's the reason behind? If she does the same thing what Louise has done, that's okay. If it's different, So what are the reasons behind it? Why did she choose those options?
So if Louise has referred the patient on, why would she not refer the patient on?
That's correct. Yeah.
And any other suggestions or things that you might ask her about?
I think too she should, you know, be inquired as to what she would have done for follow-up and where would she go from here if she found herself in this situation without Louise.
So where she would have gone from here without Louise,
What would happen once she referred on? Would she be planning follow-up? What would she be trying to organise to follow up as well, to try and prevent this client finding themselves in this situation, or, you know, perpetuating the current situation she's in.
Any other comments?
I suppose I'm just very interested that during the conversation, consultation, and afterwards talking to the GP registrar is around that this woman's changed her mind potentially. That's what she's come in for. So she's coming for a referral for a termination at 14 weeks. So that circumstances and situations change, and that you know, the event of an unexpected and earlier than planned pregnancy can be, as this woman has said, you know, welcome, and then situations change in people's lives, and then they have to look at, so asking the registrar, the doctor to reflect, or the registrar to reflect on, you know, kind of what are the reasons why this woman actually has changed her mind, and how would she manage that in terms of this progression from finding out earlier on, you know, that she was pregnant, and now at 14 weeks having to make this decision, and not only, you know, kind of making the decision that she can't continue with this pregnancy, but also all the other complications. And so I'd be very interested in getting the feedback from the doctor about understanding, you know, how does she understand, and how does she feel about that woman changing her mind, and how would she manage that, I suppose.
So I think that the key word I wanted someone to say was feelings. And I guess that's the message I want to get across, is that rather than make it like a medical model, well, what sort of follow-up plan would you have for it? Just how did you feel listening to a story like that? So we all, I know everybody here on this webinar has heard stories like this before. Juan might not have. She might not have been exposed to a story like that yet. And it's a pretty full-on story, isn't it? It's a pretty challenging story when you first hear about it, you know? And I'm going to give you a couple of, again, fictitious responses, but they're an amalgamation of responses that I have had in similar situations when I've sat with the resident or registrar. And so when you're talking to Juan about how she felt, the first thing she says is, I had no idea that women could get back into another abusive relationship. I had no idea that would happen. Wouldn't she know that he was the same as the guy before? Why did she do that, Patty? Why did she do that? And what I'm and I'm speaking as Juan here, what I'm struggling with is, if we give her an abortion for this reason, that doesn't fix the domestic violence, does it? And how would we respond as clinicians to that kind of a response? Was Dale going to say something? No?
I will, but I'm grappling with a 16-month-old.
Yeah, you were doing really well.
Thanks. Hi, everyone. I'm Dale from Children by Choice, if we haven't met before. So really interesting conversation. And obviously we sort of, you know, have a lot of instances with these sorts of situations. And I guess it's about, like, what sort of warm referral pathways have you got to make sure that that support is continued to be offered, you know, outside of what you can do as a sexual and reproductive health provider or a GP, you know, whether that be domestic and family violence, you know, support or counselling, yeah, what sort of, I guess, linkages within the community. And I think, you know, empowering the registrar to also know that, you know, you don't have to solve everything yourself either with all of these complex issues that someone might present with, that, you know, you can also find a way to do those warm referrals within the community to get the best support.
I think I'm just gently suggesting that there's maybe a little bit of blame the patient here going on, just very gently, that her conflict is so much that she's saying, you know, we're not going to fix that. She's probably going to find another man. And this is in a similar situation. This is a person who's had trauma. And I'm just wondering if trauma-informed care, and if anyone wanted to talk about how you would explain to a young registrar who's probably not, she's done, if you ask her what her runs were before, she's done oncology, she's done pediatrics, and she was quite interested in being a dermatologist for a while, but it became repetitive and boring. And then she went into general practice. So she hasn't really been exposed to this kind of stuff. She's seen end of life stuff. She's seen very, very sad oncology stuff and ped stuff, but not maybe as exposed to this. So any suggestions about how we might respond to someone who's going, you know, on the very gentle end of, some people muck up their lives, don't they? You know, and here she is at 23 and she's really made a mess of her life. So what is doing an abortion going to fix? I'm sure some of you've had those kind of discussions. Anybody want to say where you would go with that?
So being non-judgmental with the patient. So it's very important as a clinician, not because we come across so many consultation, and knowing the registrar is quite new to this type of a scenario, offering her support to the registrar, and also not to be very judgmental about the patient who is presenting in front of us. And also making sure that we are open, we are listening to the patient, offering that kind of a patient-doctor relationship, developing that rapport with the patient. So offering her support and making aware for the registrar the services that's available locally so that she can get help. I think those are some of the things, really. That's.
Yeah, definitely. I was also going to suggest, and I'm just moving it along because I've got another slide and I've got about 10 minutes more to go, was that maybe gently we could talk about what is it about this woman probably that has resulted in her having a partner who's violent. Is it something to do with her childhood, the trauma that she suffered as a child, that if that was childhood physical abuse, she's got an unusual skewed view of what it is to be loved, and that love in her life may have been very much mixed up with violence. And so it's that sort of issue in her life is what's leading to the partners that she's choosing. And that if we look at it in terms of the trauma she's had in her life, that we could maybe understand her better, rather than the all too common narrative of, you know, you make your own reality, and, you know, some, and I'm not saying all of them, but some of the evangelical Christian groups are really good at that. They're really good at saying you make your own reality. If you give to this church, if you worship at this church, you will become prosperous and you won't have badness happen in your life. And the corollary of that is that bad things happen to people who are not following the right path. So it's almost worth exploring that a little bit. And so I suggest that we might do that with Juan on this occasion. The other thing was to share with you that Juan's other reflection also showed a degree of hopeful reflection, I thought. She also said, you know, I just thought that people who went for an abortion were lazy and they didn't use contraception, because we learned at med school how good contraception was, and it's really hardly ever got a failure rate, And you know, it's only the people who don't use contraception that need an abortion. And I'm just thinking that this woman actually was wanting a pregnancy, and now her life is destroyed. So that's the other type of thing that might have happened out of that discussion post. Anyway, she does watch you handle the situation brilliantly and discuss all the other supports, and suggest that you have a follow-up after she's had her procedure somewhere else and she comes back to you. So we'll leave it at that. And Juan is a very thoughtful individual, so she's thinking about all of those things that you said about a person's life and how it might inform how they might live and make decisions in the future. And then number 3, the third act, Juan receives a phone call. You might remember that I told you her brother was an engineer, so he's a non-medical person, very logical person. And he is older than her, and he rings her one weekend for advice. He and his wife, who he's been married to for 7 years, have been trying for 5 years for pregnancy. They had unexplained primary infertility, and they had success on their first embryo transfer. They're now 13 weeks, but they've just received the news that day that the NIPS test that his wife had has returned a very high risk of trisomy 21. So he's seeking advice from Juan, who's the person that he trusts with medical issues, because she's a doctor and she is his beloved younger sister, and he really respects her. And he wants to ask advice and a referral, because what he says to her is, you know, I watched our sister destroy our mother's mental health, and what happened with our sister and how our father wasn't there for our mother. And I don't want to be that man. And we went and had this test because we didn't feel that we could cope with a baby with disability. And now we've had the result that we dreaded. Tell us what to do, Juan. And Juan comes to talk to you, Louise, because you're the only person. And Louise the part of Louise can be played by anyone in the group, please. Because you've actually been the only person that has actually gone to awkwardness with her. And this is the role of the mentor. So, Erin, what would you might say to your registrar if they said to you, you know, this is really turning my world upside down?
I think, again, first of all, how are you feeling? What's your feelings? Explain that this is a complex situation, and even though, you know, and even more complex when it's a family member, do you feel comfortable in giving your brother advice? Because you have always the ability to say, look, this is your life, your decision. I respect your decision, but I can't give you advice because I don't want to be involved in the process of the, you know, adding to the final decision that you make. Not knowing that there is options for both Juan and her brother, and, you know, trying to educate them about the options and the support services, you know, outside just themselves, that are available. That's where I would start.
Yeah. Any other comments?
I would think that it would be a great opportunity to have after you've done all that stuff, like checking in how they're travelling with it, but to demonstrate how every person who comes with an unplanned pregnancy or a planned pregnancy that they decide that they need to terminate because the circumstances have changed, that it's important to listen to the person's story and to put their needs at the centre of it. So it's a good way to highlight that it's not about you and it's not about how you feel about things. You could be completely against someone having a termination, but your role is to listen to them and hear what they want, and then help them make those decisions just by giving them the information that they need so that then they can make an informed decision. Like, it's a good opportunity to, because they know those people personally and they're personally involved, so they can feel how they're feeling and sense their upset and frustration. It's a good way to sort of highlight that everyone's got their story behind why they want to terminate their pregnancy.
Yeah, I think that's really important, Marianne. And the people I can see, I can't see everybody, but the people I can see, they're all nodding vigorously as you say that, you know, that it's about really actively listening and honouring the story. And I deliberately made it a story where childhood experiences were so important. So that's really informed this incredibly logical and thoughtful brother that she has, who she sees as making very rational decisions and being very deliberate in his desire with his wife for fertility and to offer a family, and having his and her caveat around pregnancy, fertility and parenthood challenged, because this is not the kind of child that they feel that they could look after. So
and it also highlights that she knows their story and he's telling her that story, and it makes sense to her. But, you know, you could use it as an example to say everyone has a story, a backstory. Yeah, we don't know what that backstory is.
Yeah.
And so therefore we have to trust that they're telling us that for them this is not right for them at this time.
And we were in the very privileged situation that Josie did share her story, but she may not have shared all of her story, you know, or the degree of the abuse or the nature of the abuse. But, you know, we have to trust that she's made the decision that's right for her, or help her to make the decision that's right for her. Any other comments?
Just in terms of the right decision, Patty, I was also thinking that, like, in a sense, there isn't a right decision. There's a kind of a good enough decision, the one that fits the circumstance at the minute, and, you know, and to acknowledge that it is a really tough decision. And situation to be in.
There's another thread here that you may or may not want to explore, which is the whole, you know, a good enough reason for an abortion for some practitioners. And we've actually surveyed obstetricians and gynecologists about their support for abortion in various circumstances, and found that this was done back in 2012 after abortion law reform, that more of them supported abortion for fetal anomaly than for what they referred to as psychosocial reasons. And so this is a thread in conscientious objection too, that, you know, there are reasons that are okay and reasons that are not. And often a fetal anomaly is referred to as a medical reason for an abortion. But one of the things that I have liked at times to explore with my bioethics students and with my medical students and my registrars is Down syndrome a medical reason or a psychosocial reason for having an abortion? And most of the time it's a psychosocial reason, because it's a family crisis. And a bit like your comment, Mary, I bring it back to family crisis and caring for the family that you do have, and making very difficult decisions and balancing equal bads, as Kath would say, you know, the good enough decision, balancing one thing against another. And even just sitting with that uncomfortableness that we advocate screening, but we don't, as a society, but we don't actually talk about the follow-up for the screening. That would imply that you would need more providers to do the work after you've done the screening. So it's another area. And Juan, if you want the end of the story, Juan asks your advice, gets a referral, and gives it to her brother and his wife and wishes them all the best with what the decision that they make will be. And she reflects on it over time. And then if we fast forward another 6 months and she's ending up the practice, and she talks about wanting to do further work in obstetrics and gynecology and women's health, and that she's starting to feel that she might actually need to do a bit of work on herself and really think about her values and possibly become more involved in abortion care. So it's through that thoughtful process that she's starting to think that way. So that was all I wanted to put out there in a slightly fictitious way. Any final comments about this approach? Is it too threatening to, you know, would I or Lou or Marianne or Purnima as a senior consultant be too threatening to a young registrar? Is this an appropriate way to do this? Are there other forums? Any comments gratefully received?
I would just like to say that being involved with even fourth year medical students with Dr. Chris Sass for many years, and having this situation with medical students, it's just such an amazing opportunity for undergraduates and also with GP registrars to grow, and I think there's not enough talk about it. So if specific services like sexual and reproductive health hubs or services where, you know, sexual and reproductive health and choices are known, then it is almost a duty of care for the clinicians to have those conversations with those GPs, because if we can't have them, then their next rotation to the, you know, GP practice in the other big town where nobody does anything is not going to as well. So that's my thoughts. I thought we have to be brave and bold to have those conversations.
And I guess the thing I would reflect back is that they feel like hard questions until you start, or a hard conversation, until you start having a couple of them. And they go, okay, you know, what's the worst thing that could happen? She storms out, she leaves you. You feel upset, you cry, who knows, you know, what is the worst possible thing that could happen, you know? And I guess I would reflect that I share, as I get older and I have less to prove, I share more of my own personal story. And some of you may have heard me sharing that in a peer environment, but I have shared it. I've shared it with medical students as well. My own abortion story and my decision, and that so many women will have made these decisions, and it's not about, you know, the clever people avoiding it and the lazy and the dumb and the dispossessed having to make these decisions. So to be continued, and I'd be really interested in us having a discussion about can you at another time, I'm just throwing this one up, Kylie, for another time, can you engage and change minds of the, you know, the obstructing GP, or are they a lost cause, and is this the group we should be working on? You know, what do advocacy forums, what's our role? How far do we go? Or do we just work with those in whom the energy is best spent? You know, I think Kath and I, for example, when we do our work around Victoria, we only go where we're invited. We don't force ourselves to a community that doesn't want us to come, because we've tried that before and it hasn't worked. Any concluding comments? Or I think anybody want to say anything about what's happening in their area, or anything finally before we wrap up?
Hattie, there was a number of really great comments too in the chat function, which you probably had a chance to look at.
No, I couldn't see them when I was sharing the screen.
Yeah, so we'll make sure that we include those certainly in the notes that we write up, or Kath usually writes up, takes lead on. Thank you, Kath.
I'm just even looking at them now. So maybe Kath and Kylie will stay on and have a wee bit of a look at that and think about other topics. Otherwise, I'm aware it's 7:01 and we promised to finish at 7. So it's really nice to see you all, and thanks for your attention.